So good morning, all of you, and I must appreciate Arsha and his colleagues, Reena, Nisha, and others for their effort in organizing such an important meeting. My apologies that I could not able to come in person. However, it's my pleasure in talking to you in this platform. What I'm going to talk to you is that all of you are aware that in India, it's one of the nation where you find large number of rare diseases. I'm going to tell you, so what is the reason for having such a huge number in India? I'm a population geneticist. I have been working in this area for last 30 years. I'm going to tell you that how studying the population genetics helps us in better understanding of health and disease in broad and rare disease in particular. So India is an ethnic museum because we have collection of large number of population groups. And as you see here, we have population similar to Africans. We have population who look like Europeans. We have population who look like Southeast Asian. We have also a population who are typically like Indians. The reason for this difference is that population in India and South Asia are stratified in many ways. One of the stratification is based on the language. We have four major linguistic groups like Dravidians, Indo-European, Austroasiatic, and Tibeto-Burman. And also there are some isolated languages like Andamanis, Nihalis, and few more. Again, under each linguistic group, there are several languages. For example, if you take Dravidian language, you have Tamil, Malayalam, Telugu, and Kannada. Similarly, other major linguistic groups also has several languages. Under each language, there are several social groups, so-called upper caste, middle caste, lower caste, tribes, and primitive tribes. So all of this makes India is one of the complex nation. And some of you may not aware that in India we have 4,635 anthropologically well-defined population groups that include several caste group, tribes, primitive tribes, and some of them still follow hunter and gatherers lifestyle. That means just go and hunt for food. They don't do any job, including agriculture. So in this context, I wanted to tell you that how such a complexity arose in India. We all know that the human population, or Homo sapien arose in Africa about 200,000 years back. And the question is, how did they migrate to spread rest of the world? So one of our studies showed that the Andaman tribes are the first modern human who migrated out of Africa and reached Andaman and Nicobar Islands about 65,000 to 70,000 years back. So that's the first modern human who migrated. That means India is still having a population who have migrated out of Africa for the very first time. And subsequent studies showed that in India, there were two founding populations. One, we call them as ancestral South Indians, who are closer to Andamani. That means they are the first modern human who migrated out of Africa, and they are part of this early human migration. The second one is ancestral North Indians, who probably migrated much later, and they have some kind of affinities with the European. There are several studies which have proven. I don't have time to tell. Just quickly say that the skin color mutation, which is present in Europe, Middle East, and also northern part of India, but not in southern part of India. All this says that there were two founding populations in India, and they gave rise to many populations. On the other hand, if you look at this PCA plot, where you see this, the European HapMap sample, Africans and Chinese, there were many individuals, but they are in a single cluster. Whereas look at Indians, each population is very unique. They follow endogamy, therefore they preserve their whatever the mutation takes place in that particular population. That's what makes them unique. But on the other hand, although they are unique, but still each population have some kind of genetic affinities with the other group. Okay, that's very, very unique in India. So now what I am going to give you is that when this admixture took place between ancestral South Indian and ancestral North Indians, in this study, what we have shown, initially these two groups were independent, but independently they gave rise to many population groups, both ancestral South Indian and ancestral North Indians. And these two groups have admixed during the last 2 to 4,000 years. That means the genetic component have mixed between these two groups. But what happened last 2,000 years is that every single population after admixture started maintaining the endogamy. Endogamy means marrying within the group. So 2,000 years, every population marrying within the group makes every population very unique, because the genetic mutation which happened in every single population remains in that particular population. So this probably because of the caste system which arose in India or South Asia, put every population strictly marrying within the group. So now what I'm going to talk to you is that how that has impacted on our health and diseases. So to understand that, we took another study taking 2,800 individuals from 275 population all over South Asia, including Sri Lanka, Pakistan, Nepal, Bangladesh, and other South Asian countries, because our other study, which I'm not showing here, tells that whatever you study in India, it's also true for other South Asian countries. Okay, so in this study, what we have shown is actually there's a possibility that every single population, at least 3/4 of the populations are expected to have a population-specific mutation which might cause population-specific diseases. So here, what I am showing, but I don't want to confuse you with this IBD score. Every single line represents one population. The line is shorter, that means the IBD score is less. The line is long, the IBD score is more. If the IBD score is more, there's a more chance that the population might have a population-specific mutation which might cause population-specific rare disease. You can actually see here the Ashkenazi Jewish and Finnish population. You know that the large number of recessive disease has been mapped, but they have very tiny IBD. But you can imagine that in India, large number of populations are having multiple fold of IBD score. You can imagine that how many such disease might exist in Indian subcontinent or South Asia as a whole. To understand that, we took few populations, including Kallar, Yadav, and a few more, because until then we don't have any clue that whether these populations have any disease or not, because these are purely selected for understanding the population history. While we selecting these, some of the populations, we have done the exome sequencing to understand is there any mutation which is highly prevalent in this population. While doing this, we collected additional sample. We also inquired at the time whether there's any disease in those populations. Then we found that in a population called Kallar, that is that community live in 3 or 4 different locations in South Tamil Nadu near Madurai, and we found there's a disease called junctional head-lids epidermolysis bullosa. When we collected the sample, because these children with skin rashes and congenital heart disease, they die in very few months after the birth. Parents are absolutely fine. There are multiple children dying in the family. Then we did the exome sequencing in a family. We found that the parents are with heterozygous mutation. That means there's a 11 base pair deletion in LAMB3 gene present in one copy of the gene. Other copy is normal in both the parents. But the children who are dying, we could be able to do the exome sequencing and found that there was a homozygous mutation. That means the parents, because of the endogamy, this mutation must have arose somewhere in that particular population. But it got well spread because they marry within the group. And because it's a recessive mutation, it doesn't affect the individual with heterozygous mutation. So what we did, we have looked at the family. There are 8 such families where there is a multiple death in the community. Then we went on to screen the population. Before that, we have identified a mother with pregnancy, a few months. Then we brought that mother to Chennai because it's very 300 to 400 kilometers because there's no facility at the time to collect the amniotic fluid. We did simple PCR test and identified this is amniotic fluid. This is a homozygous mutation, heterozygous mutation. We found the mother carrying heterozygous mutation. Therefore, we advised the mother to continue the pregnancy. And I am happy to show that this child born in last June with the perfect healthy condition. So that's gives us the satisfaction that whatever the basic study which we have done actually leading to some kind of application and try to help the population. Then we wanted to screen the entire population. Therefore, we organized a camp and we collected the samples. And in the meantime, we also found mother with pregnancy. And this time, we could collect the amniotic fluid in mother itself. And fortunately, that mother also carrying fetus with heterozygous mutation. So having this background, when I was heading the Center for DNA Fingerprinting and Diagnostics, I initiated a new program called Mission Program on Pediatric Rare Disorders, okay, which was funded by DBT. And there are some 20 different institutes all over India is participating in that. And just we had a progress a meeting and found that it is progressing well and it has several components. Identify the patients and their family, do the exome sequencing or the whole genome sequencing, and do the animal model, different animal model, and also try to do the therapy using lentiviral method. And also we wanted to advertise with various means. Therefore, the common people will know about this particular study. Therefore, we can help those family. And in fact, this was launched recently by the Secretary, Department of Biotechnology, when I was in CDFD. I'm sure that it's going to help the population with the individual family with rare genetic disorders. So how actually it means to the population which are living in US? The Indians who have migrated to US, because the initiative, I think is well conceived, that Indo-US, because the population, some of the individuals with the heterozygous mutation who are healthy, who migrated to US, and they marry someone with similar mutation, there's a chance that they would have, they get the children would get the disease. But I don't have the example to say in US, but I have the example to say in UK. I've been collaborating with the Institute of Neurology from University College London, where my collaborator asked me to check for a mutation, which they found in 3 Indian families. But initially we didn't say, but they have looked for the mutations in these 3 families, which are known to cause a mutation in the European, but they could not find. Therefore, they have sequenced the exome and identified a mutation which causes mitochondrial diseases. This is also a group of rare diseases which is present in a gene called RNA-SEH. But when we try to look for the mutation in the mitochondrial disease patient who are from South India, we did not find that. But when I asked him, where did these patients have come from? He said that they are from Gujarat. Then I explained about the complexity. So India, again, is not considered as a whole because every population is very unique. That's another challenging. to identify and treat these patients. So that's what I wanted to highlight, and I think I appreciate once again Harsha and his team for taking this initiative while we are trying to treat the patient with the existing drug or new drug, but we try to understand the cause and try to prevent that in the next generation. So with that, I would like to thank all my colleagues and students who are part of several other studies, and funding has come from various organizations. And thank you very much.